The process of PE was not well organized, and it depended on the emergency doctor that was at charge at that day, and depending on what he thought, maybe the patient was admitted in the internal medicine department or geriatrics or pneumology, depending on not a clear criteria. But I think we have made a change because we have now technology, and the intervention, the thrombectomy has been a game changer for us.
In the last 20 years, there hasn't been too much of a change in terms of mortality. And if you take the high-risk patients, you will find something around 30% mortality, even 40% mortality, and this has remained unchanged for the last 20 years. And also in the intermediate to high-risk scenario, the mortalities can range from 5 to 10%. And as you said, this wouldn't be acceptable in STEMI. So if we had a center having maybe in the non-shock patient with a myocardial infarction and a mortality around 10%, probably the authorities would go and close that hospitals. But we accept this as normal in PE. I think the big shift was to go knock some doors and talk to the different actors that were handling PE, and we told them, hey, let's sit together and agree on a general framework for the PE management. And if we can all agree in one framework, I think we can everyone push in the same direction. What do you think?
I agree with you. The problem was that nobody was leading the process of pulmonary embolism, so I think we needed someone to lead it, and I think from the cardiology department we began to organize the process.
I think you mentioned a very important point, which is leadership. Yeah. Sometimes you wait for the hospital to make a move, and this is not going to happen. Sometimes you need a leader that can be anyone that really wants to put things together around PE, and this leadership should be very inclusive.
We started the PER team with the emergency department doctors. We were like, okay, we have more treatments now, we can offer something different to these patients. So we included also, of course, the radiologist in the PERT, and then the interventional cardiologist, ourselves, the acute cardiac care doctors, and also we have for the follow-up the pneumologists, the internal medicine, because they do the follow-up in the outpatient clinics. And when we started this PERT, we created a WhatsApp group. It's as simple as that. And so now I think the doctors from the emergency department have more awareness about this disease, because this starts with the suspicion, the clinical suspicion. You have to make a very good medical history. And we are, I think, making more diagnosis now of PE with the same patient, so it's because we are doing better. And when they ask for a CT scan and they diagnose the PE, they call us, the radiologists, they call the acute cardiac care doctors, and we go to evaluate the patient.
I think many people, when you talk about PERTs, think that they are overloaded with work already. So is this gonna take a lot of my time? And to tell you the truth, people are doing their best. And sometimes when you provide them with an easy solution for those patients that are complicated, actually you get less work from this, because you don't have to think it for yourself, but you will have a partner that knows more about this specific than you. Whenever you have to think on coagulation disorders, I don't have to study from the book. I can call the hematologist, who will already know me, that I'm involved in PE, and they will give me the answer. Whenever I am unsure of these comorbidities, I will consult the internal medicine guys, and whenever they need an echocardiogram, they will call us, or whenever they want to decide on a critically ill patient, they will call us. And whenever they are considering an intervention, they will probably call me and say, hey, Pablo, what do you think? This patient could do well with mechanical thrombectomy, or do you think it's okay to stay in medical therapy? What we found in our PERT, after 3 years of working is that we found a decrease in mortality compared to historical data, but we didn't do this just by building the PERT. We look at the numbers and we increase reperfusion twofold. So we went from 12% reperfusion to 24% reperfusion in the segment of intermediate high risk and high risk.